I think we're ready to get going. Welcome to the National Press Club. My name is Josh Sharfstein. I'm the Associate Dean for Public Health Practice and Training at the Johns Hopkins Bloomberg School of Public Health, and we're here to talk about rising drug costs and where we go from here. We have an incredible panel that you will soon hear from. I think my job is to just make a few opening remarks, and then we will jump in. So I have 3 opening remarks after thanking Stephanie Desmond and the whole team that put this event together. The first is we're here because drug costs are a major challenge, and that has a numerical face, meaning that you can look and say costs are growing 10, 11, 12% a year, far quicker than wages, far quicker than overall medical cost growth. But what does that really mean? I think the consequences include higher healthcare premiums that we're all paying. They include the fact that their individuals, for many reasons, can't access medicines that they need because their deductible is so high, or their copayment, or because they're uninsured and they can't access a program to get drugs at a deep discount. And the third thing is it inhibits our ability to actually address public health problems. And my background's in public health. We all work with the School of Public Health. And when you have a challenge like hepatitis C, for example, which is a transmissible and deadly disease, when people can't get the treatment because of the price, we all are at risk because there's just a lot more infectious disease in the community. So it's a major challenge. The second issue is that it's an understandable challenge. People understand when their drug costs are going up. People also understand when things don't make sense, like when someone buys a company that makes a pill for less than $1 and suddenly it's a few $100s. That doesn't seem fair really to anyone. And I think one of the reasons there's such a focus on drug costs is that it is so clear to people, and in many cases so enraging to people, what they see on the news and hear about. And the third reason, I think, is because there really isn't light at the end of the tunnel at this point. You know, there are different ideas that are out there. None of them are really moving forward. None of them necessarily have the confidence that they're actually going to bend the curve. And so that and in fact, things could get a lot worse. And I don't know what the weather vane is on Capitol Hill's approach to the Affordable Care Act today. But you know, if you take 24 million people off of insurance, that generates pressure to get as much out of every insured person for pharmaceuticals as possible. And it is entirely predictable that drug costs and prices would significantly rise in that setting. So. In fact, there are companies today that justify their high prices because they say they want to make drugs available for people who can't afford them or might be uninsured. Well, if you increase the number of uninsured by 24 million, it is entirely predictable that you would see that shift continue and could really worsen all the different challenges that we have. So it's a major problem, it's understandable, and there's no light yet at the end of the tunnel. So that's really a good reason to bring everyone together and talk about the solutions. I'm going to let the moderator, Sarah Jane Tribble from Kaiser News, introduce my colleagues, but I will tell you this, listen to every word they say. They're like jewels coming out of their mouths. They're incredible how much I've learned from each of them, and this is really fun to be here and talk to you all. Thank you. Sarah.
And we're professors, and there's the quiz at the end.
Yeah.
Well, I think my job's going to be pretty easy today with these folks up here on stage. My name's Sarah Jane Tribble. I cover prescription drug prices on the enterprise team at Kaiser Health News. So we do kind of long-term projects. And so I get the opportunity to talk to folks like this all the time and learn from them. And I was reading the New York Times a couple of weeks ago, and it was an opinion section story. And in there was a quote, and I was thinking about this panel, and there was a comment, and what it said was, "We are living through a period of mental hyperinflation. Ideas, prospects, and spectacles go from unimaginable to ordinary in weeks or even days." Now, this column was not about prescription drug prices. It was about politics and truth. But it struck me that it could be about prescription drug prices. With the news that we hear every day, it seems every other month we're hearing about a new drug that cost a lot of money that we didn't expect to cost a lot of money. I was recently writing about influenza, a common steroid, so to speak, that's sold in Europe. People with Duchenne muscular dystrophy were bringing it over for $1,000, $1,200 a year, and then when the company Marathon Pharmaceuticals announced it, they announced it at a price point of $89,000 a year, in part because they had thought the market would bear it with the insurance companies covering that price. So these things are happening kind of on a consistent basis here in the US. And so this idea of what is acceptable, what's normal, is constantly evolving. And I'm hoping to talk a little bit more about that today with some of the bills and the legislation that's out and some of the news that we've heard. So kind of setting that stage of what's unimaginable and where we're at with pharmaceutical prices, I'd like to introduce the panel. You guys have met Josh, who's a go-to guy when it comes to talking about the FDA and prescription drug prices and drugs in general. We have Jeremy Green, an expert on generics. He's also a practicing internist and a medical historian at Johns Hopkins. And if you haven't picked up his book, Generic, The Unbranding of Modern Medicine, I'll just do a free advertisement for it here because it's very good. We have Dr. Caleb Alexander, also a practicing internist and co-director for drug safety and effectiveness over at Johns Hopkins. Aditi Sen is also a faculty member over at Johns Hopkins. She's an economist by training and has a particular interest in how providers and payers interact in the market. Aditi's recently worked in the Office of Secretary at HHS and elsewhere in the government, so she knows kind of the halls of Capitol Hill very well, if you will. And then, of course, Jerry Anderson is a professor of health policy and management at Johns Hopkins. He is a familiar face on Capitol Hill as well and testified just last month at the House Oversight Committee. So kind of setting the stage with that, those are our experts here on stage. And I'd like to kind of turn to Aditi first and talk a little bit about some of the proposals we've seen on Capitol Hill. Just last week, Senator Franken came out with his 130-page proposal. Before that, Senator Cummings and Representative Welch had gone to the White House to meet with President Trump about Medicare price negotiation. There's a common theme in both those, with Medicare price negotiation being something that's a topic that's been frequently brought up and is in both of those proposals. When we talk about Medicare price negotiation, considering there's already PBMs in the Medicare Part D formulary who help negotiate prices for drugs kind of on the forefront, what more can we expect to happen, or what more can be done when it comes to price negotiations in Medicare?
Sure. So I think an important place to start is that drug spending makes up about 16% of Medicare spending overall. So it's not the majority, but it's certainly the fastest growing. And Medicare relies on Part D plans, as you said, to negotiate and to use sort of direct negotiation, and also use formularies and other sort of means of utilization management to keep prices reasonable. And I think in a lot of cases, we've seen that work fairly well. But now we're seeing this sort of influx of high-cost specialty drugs where there are no competitors or very few competitors. And in that case, even sort of theoretical economics, the market kind of breaks down. And so I think we might think about using value-based pricing or more sort of different types of negotiations in those cases, especially where we are seeing the market kind of break down and the existing structures not work that well.
Now, some of you have written about value-based pricing before. Jerry, can you talk a little bit about what you mean by value-based pricing? This is a proposal that several of you have written about.
Well, we've written about a variety of different things, one of which is called bundling, and that is essentially bringing pharmaceuticals into the bundle of services. So as part of value-based pricing, what's happened is the Medicare program has put hospital services, physician services, and home health services into bundles to take care of things like knees and hip replacements and those kinds of things, but has not really continued to put pharmaceuticals into those same bundles. And pharmaceuticals are a very important part of how you would take care of someone. And if they're not part of the bundle, you make sort of very strange choices about how much to spend on the drug versus how much to spend on the other goods and services. So one of the things is about value-based purchasing is to include them into the bundled payments. And there are a series of other approaches that are part of value-based purchasing, which in general have not included pharmaceuticals into those mechanisms in most cases, like the ACOs and other things. So there's a whole set of things where I think pharmaceuticals are ripe for value-based purchasing, and so far have not been there.
So when it comes to the bundles, how long have those pilots been happening in Medicare, and are they showing cost savings as they are right now?
So worked in the Assistant Secretary for Planning and Evaluation's office back in the 1980s and helped design the DRG system. And the DRG system is our first bundled payment system. And then what we've done is added to that over time. We did it in cardiology in the 1990s, and really in the last 5 years, we've added a whole series of bundled payment systems. The one where pharmaceuticals are included is in end-stage renal disease, where the Congress mandated that drugs be included in the bundles for ESRD, but Congress or the administration haven't chosen to do it in other areas. So I think that's something that the new administration might want to take a look at. It's really about value-based purchasing, but it puts the onus of determining the value on the patient and on the physician, which I think really does make sense.
Well, that would be in the hospital setting. What about Medicare Part D, which is the drugs that we all folks get with the pharmacist when they go to the pharmacy, or Medicare Part B, those drugs like infusions that you go to the hospital for outpatient services for? Would it count for that as well?
Well, I think it doesn't. It does on end-stage renal disease. It doesn't on anything else. So what I think we'd want to do is to include pharmaceuticals into the bundled payments for now knees and hips. But over time, as the bundles get more, there are more and more bundles and more services are included in the bundles, we might even get for diabetes or congestive heart failure or other things to be part of a bundled payment that includes pharmaceuticals, where pharmaceuticals are a much larger part. So the way you generally do things is you start very small with small components of bundled payments for drugs and learn from the experience and build from that. So what I'm essentially saying is that we'd want to build from that if we're talking about value-based in pharmaceuticals.
Right. Part of Senator Cummings and Peter Welch's proposal was negotiation of Medicare Part D pricing.
Right.
Do you see that? Do any of you seen that being a feasible option for negotiations in Medicare Part D?
So let me just continue for a moment. So what you've got to look at in Medicare Part D is the catastrophic part of Medicare Part D, which is when somebody spends approximately $7,000, then they get into the catastrophic level of spending. When they're in the catastrophic level of spending, the Medicare program is responsible for 80% of the cost. Yet Medicare has no ability under the current system to negotiate at all over the prices. The PDPs are the ones who negotiate over the prices. And what we've seen since the program has started in 2005 is that almost a lot of the growth in drug spending has occurred for these very expensive drugs. And most all of it in the Medicare Part D catastrophic amount is expenditures for these very expensive drugs. It has nothing to do with more people entering the catastrophic component. It has nothing to do mostly with the drugs that are already in the catastrophic raising their prices. It is mostly about the fact that we've had these new drugs like the hepatitis C drug and others like it essentially entering the catastrophic amount in a place where the Medicare program can't negotiate.
What's interesting is you can actually go to CMS and they have some tools where you can look up the prices of drugs and the comparison to the price the year before, and they point out kind of the most expensive drugs and the 20% increases and 19% increases in drugs year over year in just the amount they're spending, the cost of the actual drug per unit. It's fascinating to look at. Now, when it comes to the federal proposals, another one to kind of combat that price battle is drug importation. We saw it in the 130-page bill that was put out last week. I think a couple of you have written about the idea of temporary importation. Jeremy, do you want to speak to that idea?
Sure, I'd be happy to. And I think when we look at the question of drug importation, there's, as you know, it's a very active issue right now, suggesting that what looks like a generic drug globally is not a generic drug globally and must be titrated based on the regulatory framework it comes from. And these are arguments that come forward on both sides and many sides. As a historian, right, I look back at this from a question, 50 years ago, when there was a similar set of debates about whether there even was any such thing as a generic drug in the United States, and arguments suggesting that a drug made from one company could not be understood to be functionally similar to a drug made from another company just based on their active ingredient. Now, since that time, we've seen the elaboration of a set of frameworks, which we often condense down to this science of bioavailability or bioequivalence, this rigid set of requirements, that a rigorous set of requirements that the FDA uses for a application from a manufacturer seeking to produce a generic version of a drug on a competitive basis to make sure that it is functionally clinically the same for American consumers. At stake in these debates over importation, though, is whether other countries' regulatory frameworks can be considered equivalent to the United States. I would suggest it's a similar debate. There is significant interest at stake in suggesting that they aren't, because it helps keep these markets closed. The suggestion that a number of us made is not that any generic drug anywhere in the world should be available to the American market, but that in times of crisis, when the FDA's regulatory approval process is used as a shield to defend what should be an indefensible monopoly, and we saw this in the case of Daraprim, that temporary importation from a limited list of approved sources could help to, on the one hand, defuse and introduce competition back into this now uncompetitive marketplace, and more broadly act as a deterrent for these kinds of rent-seeking marketing strategies. Now, if you look at the Daraprim case in particular, the original manufacturer of the drug, the company that actually did the innovation behind producing Daraprim, Glaxo, still sold that drug in the United Kingdom for 66 pence a pill in a time period where in the United States the price had been elevated from $13.50 to $750. And it's hard to understand what logics truly suggest that pill would be dangerously inequivalent for American consumers when it functions for British consumers. So that being said, there are a number of possibilities for arranging reciprocal systems to, in a limited number of regulatory arrangements, such that for limited amounts of time, importation could help to render such indefensible monopolies impossible.
And you think that should only be done for generics, not for other maybe brand name drugs?
Well, I think the proposal that we put forward was for generics. Mm-hmm. I think the questions we get into for brand name drugs get into broader questions about how we address the U.S. patent system.
Right.
But certainly in the case of off-patent drugs, I think the issue should be fairly clear. These are monopolies that should be indefensible.
And this is a proposal that several of you put out in JAMA last year, correct?
Yes.
Co-authored in a paper last year. Josh, I wanted to bring you into this conversation since you have a little bit of experience with the FDA. What do you think of the idea of drug importation and the idea of the temporary versus maybe what's been proposed in the most recent bill, the 130-page Franken bill, which is to start out with 1 year with Canadian FDA-approved drugs and then maybe possibly expand that?
Well, I think that it is important to draw a distinction between the generic importation and the brand importation. The generic importation, particularly if you're dealing with a situation where they're different companies. There's a company selling in the United States, in this case it was Turing, that had increased the price indefensibly. And then there's a different company selling in another country. So the FDA can work with that company to assure a safe supply chain, bring the medication in. That's what FDA does when there's a shortage. There's a shortage from one company in the United States. If there's another supplier in another country, FDA will do that now. They will work with that other company to make sure that there's a supply for the United States. So for us, that was a pretty easy thing to recommend. If you have a virtual shortage because someone is behaving in an indefensible manner, creating their own monopoly for no reason and pricing people out of the market, and there's a manufacturer who will work with the FDA in another country, absolutely do that. It would also reduce the incentive for people to use what we would consider an unconscionable business strategy in the first place. It's a very different issue when it comes to brand name drugs where there's only one company. So here you're not working with another company. You're trying to sort of work around that company via a system that you're setting up to rely on other regulatory systems. And The challenge there is it's not as easy to assure the supply chain all the way back because you're not working directly with the company. You're trying to find the intermediaries. And in general, my view on that is that is really a workaround to the whole FDA system. There are many important roles that FDA plays, including around the labeling, the supply chain, and others that I think you'd have to toss overboard. I understand very much why people are looking at that idea. Just work around the whole thing. Let's not try to figure out
Don't mess with the
negotiating
US
strategies
health
or other
system, yeah.
things. Let's just work around it and try to, get it from. I understand why they're doing that. My personal view is that it's much better to go straight at the problem of pricing than to do a workaround for a brand name, because I do think it introduces some risks. And more importantly, I think that a strong FDA doing its job for the American people is a better role, and a better way to think is important to consumers. I'll just say that. And you're losing that if you throw that overboard with drug importation for brand names. Whereas for generics, in times of shortage, you don't. Actually, you could do it through the FDA, just like they do now for shortages.
How often do they do that for shortages at the FDA now?
A few times a year.
Few times
I
a
mean,
year.
it wouldn't require, I think, them doing it all the time for generics. I think it probably would just be a few times a year. And then what's really important, I think, on the generic side, is if the FDA did that enough to be a deterrent. If we were all sitting in a boardroom and we said, we've got a great idea. Let's find this pill that everyone needs. There's only one manufacturer. It's being sold for $1. Let's buy the company and increase the price to $1,000. Then you want someone there to go, yeah, but FDA is just going to import it from another country. Forget it. We won't do it in the first place. Then it stays at $1. So I think if FDA were to go further in that way, it wouldn't necessarily have to be doing it all the time to create that deterrence.
Perhaps some different triggers. I know when I've talked to folks at the FDA, they're very careful about protecting public health and public health standards. They don't consider cost in their equation when they're considering drugs. For approval purposes, that would maybe get in the way of making sure those drugs were efficient and safe and had the best efficacy. So perhaps maybe having some different triggers for when the FDA could reach out and across the borders.
Well, the FDA is starting to do a lot more around drug shortages. So they're basically saying as they start to see shortage situations, they will bump generic applications up in the line. So that's a very good thing for the agency to be doing. I don't think it's that far a leap to say if literally the machines are broken down in the United States, we're going to go and import it to it. There's an unconscionable price burden. We'll go out and import it, particularly for a generic where there's no justification. And I think the deterrence effect would make a little bit of movement by FDA in that area be quite effective over the long term.
I mean, it's also. Oh, well, just a quick point about that I think that many members of the public may not appreciate, but the majority of ingredients of the medicines that we consume are manufactured overseas. So, this, I think, to Jeremy's point, there may be a perception that medicines systematically from overseas are somehow less safe, but we're taking them every day and place great faith in the current regulatory system that we have in place for those.
I should know this number off the top of my head, but what is it, 80% of generics are manufactured overseas? Is that right?
I think the ballpark in terms of the proportion of active pharmaceutical ingredients is 80% that are manufactured overseas.
Right.
What I would add in here just very briefly is that, as Josh is suggesting, there is already a public health imperative for the FDA to look into questions of drug shortages and the conditions that lead to drug shortage, right? One of the most important is a limited number of suppliers. So it begins to map very closely in the generic market space into off-patent medicines that are at risk also for oligopolistic or monopolistic price raising. So if you take that into concern, and the FDA is increasingly looking at this, not specifically cost, but the conditions that lead to the risk of monopolistic price rising, which overlap with the risk of drug shortages, there's a lot that could be done. And we've done relatively little as a country to survey the off-patent drug marketplace and make sure that it's competitive. Oftentimes we've just assumed that once a drug goes off-patent, invisible hand kicks in, it's competitive. But realizing that there is a substantial space that is non-competitive in the off-patent marketplace, and that when there are only a few or one manufacturer in the United States, many of those drugs do have manufacturers overseas, oftentimes approved by very reputable regulatory agencies. That that opens up a space that brings you back to the boardroom imagined, in which strategies for rent-seeking behavior based on a monopoly that can be defended in the United States begin to dissolve once temporary importation is available as a mechanism.
There aren't very many bipartisan agreements in Washington these days, but one of them is about what's called limited distribution chains. And that's what I testified last week about. And that's where, when you have an off-patent drug and the manufacturer of this puts it what's called a limited distribution chain, so only one distributor is allowed to sell it, and they can control who can buy it. That means that a competitor, another generic firm, may not be able to buy it. And as a result, you don't have competition. So people like Martin Shkreli put their drugs into these limited distribution networks to prevent anybody else from buying the drug to be able to demonstrate bioequivalence for that drug. So that's one of the few areas where there seems to be bipartisan agreement that this type of behavior needs to change. Because as we've said already, in the generic space, it's where there is only one competitor or maybe two competitors that we're seeing this aberrant behavior, and we need to try to figure out how to deal with that situation.
Now, I would be remiss not to jump backwards just a little bit on drug importation and point out that just down the hall there is another panel being held on drug importation.
But
Don't all leave. Yeah, exactly.
Don't leave.
Mention that at the end.
But it's interesting because this has become quite a flashpoint in the discussions. There's a couple of things that are flashpoints in the discussions right now around prescription drug prices and on Capitol Hill and price negotiation. And Medicare is one of those, and drug importation is always a popular one. And there are a few others, but the thrust of pharma and bio, who are missing from this panel, is that there's already Medicare price negotiation. If you go to pharma's website, they have a page on why there's already price negotiation in Medicare. And they also are opposed to drug importation because of safety concerns. And they have a very strong stance against drug importation, saying that the FDA does a good job of protecting the U.S. There have been problems in the past. And I just wanted to kind of jump back to Caleb, if you will, and talk about this idea of safety, because we did just mention how many drugs are manufactured overseas. So how can we, on one hand, say we're concerned about safety of importation, but then on the other hand, know logically that many of the drugs are manufactured overseas?
Yeah, well, I think there are, I think the main point that I would emphasize is, as I said, that we already rely on overseas manufacturing to produce the vast majority of the ingredients of the pharmaceuticals that we consume. So, if the question is specifically about the safety of the supply chain and how it would change were, for example, one of these proposals to be entertained, I think it's going to be context dependent in part on the types of products that we're talking about, the types of countries that the products are coming from, and the specifics of the proposals. But fortunately, there are parts of the world where there are huge concerns about substandard or frankly counterfeit medicines, and those aren't problems that we fortunately, those aren't problems that we have to struggle with in this country, and many developed countries do not as well. So I think that I don't think that concerns about safety of the supply chain or safety of the ingredients or the quality of the ingredients, I think it's throwing the baby out with the bathwater to sort of use that in and of itself to reject these types of proposals.
That's kind of a basic question, if I could, Josh, and I should have asked you this like 5 months ago probably. And that is, I was interviewing a patient the other day, and I'm probably going to go visit this patient, and he is importing a drug that Medicare has cost several $100s for monthly supply, but he needs it to be less because he's on a fixed income. He's importing this drug from, I think, England. I'm not sure which country, England or Canada. And when I was talking to Duchenne patients, they also were importing regularly drugs from Britain and Canada. What are the rules around individual importation of drugs? Like, it's legal?
It depends, I think, a little bit on what they're importing and for what purpose. But for the most part, small quantities, the FDA is not interested in enforcement on individual patients, for example. I'm sure there are some rules about controlled substances and other things like that. I would just point out to your question that the supply is very different from the supply chain. The fact that the drugs are all coming from the same place or the ingredients might be coming from a common source doesn't mean that you can assure the supply chain all the way through or the manufacturing of the product. And when you're basically doing a big workaround, you're setting in motion a lot of things that you just can't control. Will the companies be really excited about selling their products way less, or will they start to write into their contracts that you can't sell? And then what's the next thing? And then just all of that is unnecessary from the standpoint of if you're really trying to get lower prices, you could just directly get lower prices. Right. And so to me, it is an understandable policy response, but it shows how hard it is just to go right at the problem to have to do such a big workaround. And if you went right at the problem, you'd not only get lower prices, but you would not have the concerns about the supply chain and all the chasing that you'd have to do to assure that you're really dealing with the product that you thought was made where you thought it was made.
And not to mention the countries themselves, what they want, they don't want their supplies to be affected or their prices to be affected.
Exactly, right. I mean, there are all these potential things that could get set into motion, and all of that is like extra work for the purpose if what you're trying to do is accomplish low prices. There are proposals out there to say, companies can't charge more than X% over the European price. If that's what you think it should be, that's a potential piece of legislation that people could go for. And it's just, then you would have FDA approved product, right there at whatever price. I'm not necessarily saying that's a good blanket proposal, but like actually thinking about drug pricing proposals is better. And I think one of the reasons people are pursuing importation is to get people because people understand that. Yeah. It's understandable. It's obviously unfair that other advanced economies are paying so much less for drugs than the United States is. And so that understandability makes it more real for people. And hopefully, I hope that kind of discussion will bring people to the table for solutions that actually lower the prices and allow you to still have FDA oversight.
I thought that Franken's proposal last week was interesting in the fact that it was a number of different proposals all in one bill, and you could almost cherry pick different things that you might want to see move through Congress and make into individual bills or kind of pile into PDUFA or what have you. And let me kind of, as you talked, Josh, I was thinking of two of the different proposals in that bill. And one was this idea that you would take Medicare and have it negotiate prices with a ceiling cap, I believe, with the VA. So if you couldn't negotiate that drug price as low as the VA is getting that drug price, then you would just take the VA's price, which is interesting in itself because the VA can walk away from drugs, right? Medicare is not supposed to be able to walk away from a drug. They're supposed to sell most or have most drugs on their formularies. So let's kind of back up there. But we could also talk then about the other proposal, which was to decrease patent times for biologics. That's also in that 130-page bill. Let's start with the Medicare one, if we could. This idea of having Medicare negotiate, and if it doesn't succeed in negotiating, then taking a VA price. Why or why wouldn't that work?
I think it's an interesting proposal just to start out with. I mean, I think, as you said, one of the sort of pushbacks against Medicare negotiating prices has been that because they can't walk away, they actually don't have a lot of leverage. And so just sort of, allowing for negotiation may not actually bring down prices as much as we would like. And so I thought this was interesting to give it some sort of a cap and, that if, they give them a year, I think is what the proposal said. And if they can't reach agreement, that Medicare has a sort of guardrail at the VA price, which would hopefully bring parties to the table and make those negotiations more effective. So I thought it was an interesting.
Yeah, but the problem with that though is if you put everybody on the same tier with the VA, then doesn't that send a different kind of message for kind of the economic circumstances for the drug companies themselves?
Well, I think it would hopefully serve as a deterrent, as sort of an incentive to get to a negotiated price, as opposed to ending up with, the Medicare at VA prices sort of writ large. Although, and Jerry talked about this sort of interesting, there are interesting dynamics across the federal government, and the fact that the VA, Medicare, DOD, Medicaid all have such different pricing schemes as I think an interesting development, and one that we could take a closer look at that might warrant a closer look.
Right, that tiered pricing system we have set up inadvertently in the U.S., so to speak.
Exactly.
Jerry, you were going to say?
You can negotiate, but then not everybody agrees with you when you negotiate, so you have to have some kind of fallback position. So if you think of baseball players negotiating, what you have is the management with one thing an arbitrator coming up with another price and the player wanting another one, and essentially you default to the arbitrator's price if they can't agree with this. So essentially what Franken and others are trying to do is saying, if there is not an agreement for these, and what is the reason for a drug company or Medicare to come to a reasonable price, we've got to have some kind of alternative. And it could be that, it could be the prices that are being paid in other industrialized countries, or it could be a price that's value related. There are a number of entities out there that are trying to determine the value of a drug. How much does it save the economy, and use that as a calculation. So what they're looking for is a series of fallback positions that they can use if there isn't a negotiated price that works.
Let's talk about the value just a minute, but I had a big smile on my face because last night was opening day, and it was a good opening day. I come from Cleveland. The Indians had a very good night.
That's a pretty good day, too.
They did. So it was a wonderful opening. But I also, since coming to DC, this idea of the baseball analogy has come up a couple of times in conversations, that you would get this negotiator in the room, and it would be a binding negotiation agreement. So nobody could walk away from the table. Somebody has to take a deal. And ideally, you could do this with the most expensive drugs that maybe don't have any competition, right?
Correct.
But then the companies would still have to sign on for this idea of making sure they stay in the deal, right?
Right. Or Congress could write laws saying, there is some kind of binding arbitration if we can't negotiate a fair price or a price that we can agree on, and it would be this amount. And it could be what other countries are paying. It could be what an ICER type of organization develops is a value-based price, or something else.
But do you fear that a company like Kaiser could come in and say, we're going to walk away from this country, as they have done with some drugs in other countries? We're going to walk away from the U.S. Medicare system because we don't want to deal with this price negotiation. We don't want all our drugs to be priced at the Medicaid level or the VA level.
Well, they certainly could do that. You've also got to recognize how much profits they get in the United States vis-a-vis other industrialized countries. So, they're certainly not going to walk away and say, we're going to make so much money in the UK or France that the United States is not a good deal for us. I mean, they're going to get their best deal from the US, the best deal from France, the best deal from all these other countries they can, recognizing that the cost of manufacturing a drug is very, very low. So you earn a great deal of profit for every additional drug you sell. You incur a huge fixed cost, sunk cost to develop the drug, but then once you've developed it, you essentially make the pill for pennies or for dollars, and you sell it for a lot more, and that's where you earn your profit. So they're not going to walk away from the U.S. market.
Well, just to pause, I think some drugs, therapies cost a little bit more than pennies or dollars to make, if you think about enzyme therapy, replacement therapies, and so forth. And then just kind of backing up, and I glance over at Josh, because I know we've talked about this idea of value-based pricing before. If you talk to pharma, the lobbying group for the industry, and to bio, they'll point out the Tufts University calculation of $2.6 billion for the development of drugs. It's just a general calculation. There's been a lot of controversy around that number. If you start calling around, as I have as a reporter, asking about how much it costs to develop a drug, you get anything from $200 million to $5 billion. I mean, it's just all over the board. And that's in part because of transparency reasons. You don't see those development costs. Actually, the 130-page bill we've mentioned a few times has some transparency rules in it. If you want to go back and read those, they're interesting to view. But there is something, I think, to be said about the idea of developing drugs. I do think that pharma, when you talk to pharmaceutical companies and they say that America helps pay for the development of drugs that then the rest of the world gets, they're not lying. It's true that they've got to get the money to develop these drugs from someplace. So with that in mind, how do we figure out the value that is fair for Americans to be paying? And I'll open that up to anybody to answer.
Yeah, well, I mean, I think this question of the cost of drug development comes up all the time, and to some degree, it's a lot of money. I don't think anyone would argue with that maybe it's 2 billion, maybe it's 1.7, maybe it's 2.4.
They have to pay for the failed drugs, too.
There's no question. And also the case that most drugs that are early in development don't make it to market. And that's all well and good. But I think that this question of whether drugs are currently priced for value is a really important one. And it's, I think, important in part because of the way that it's pushed discussions and efforts to develop frameworks to determine what the true value of a product is. And I think without these explicit frameworks, conversations about value can quickly devolve into a lot of related points that are sort of unanswerable and that become as philosophical as they are sort of scientific in nature. And I think one of the best indications that people aren't paying for value is that surely the value of a product isn't increasing 15 or 20% every time its price does. And so I think you'd be hard-pressed to find someone that could credibly say that they think products right now are priced for value. And if you look at the value frameworks, they incorporate, you could argue that all of the frameworks are wrong, but some of them are useful. But they incorporate concepts or parameters such as cost effectiveness or comparative clinical effectiveness, incremental cost effectiveness, the potential benefits or disadvantages of products vis-a-vis impact on caregivers or severity of disease, a lot of other factors. And what I think these frameworks are doing is they're pushing us to take a hard look at the way that products are priced and to ask hard questions about whether or not the prices truly reflect the value of the products.
The other thing that you got to recognize is that in most cases, the R&D that goes into a specific drug is not necessarily related to the price of that specific drug. So the drug company needs a certain amount of money to develop new R&D, but that's sort of it. The company, Pfizer or whatever, needs the $7-10 billion it needs for R&D, but it can get it from a whole variety of different places. So it's not pricing a new cardiology drug based upon how much it spent to develop that new cardiology drug.
Right.
And so, there is a disconnect between the R&D for that drug and the price of that drug. Clearly, the company needs a whole bunch of money to do R&D, but the question is, where does it get it from? Does it get from one blockbuster drug charging a lot, or how do they want to do that?
Right. Repatha, for example, from Amgen, they will say that they've spent years developing that drug. There are plenty of fails in getting Repatha on the market. It's around $14,900 list price with discounts being offered. And of course, now they've come out and said that they would discount the drug. They would not charge for the drug if you had a heart attack while on it, I think, for the insurer.
Yeah, I think we'll also be talking a bit more about various discounts and the ways that those work, but there's an important conversation about discounts and about the ways that companies currently are trying to, put patches on the overarching problem through, for example, coupons and discounts that patients may receive, or free drugs for certain eligible patients and the like.
Well, I want to ask Josh about patents and talk about that a little bit, but before we move on about the basic increases in prices, Jeremy, you made headlines last year on insulin and the fact that there's no generic insulins in this country, and you had a report out on that. Can you just talk a little bit about this idea? Because diabetes is one of the most expensive diseases in our country to treat, very deadly, very increasingly common. Why do we not have generic insulin? To ask a question that you've answered a few times, but
Sure, no, it's a great question. I think for me as a clinician and a historian and a pharmaceutical policy researcher, this is one of these questions where all three of these all come together at the same time. But ironically, I didn't recognize the problem of the unaffordability of insulin until fairly recently. And it was actually in switching my clinic from Boston to Baltimore and having a slightly different set of plans for which patients weren't eligible. I was speaking with a patient who was non-adherent with their insulin regimen for type 2 diabetes. And as many of you know, diabetes is a very difficult disease to manage, especially if you're using insulin. There are all kinds of reasons why it can be hard to keep up with your insulin regimen, and we think of the behavioral and psychological dimensions of this, logistical dimensions. But one thing that very few clinicians had really been talking about was cost. And I think the reason very few clinicians have been talking about this was we generally assumed that insulin was discovered in 1921. It was first patented in 1923. And so a drug that had been off patent for so long, in the mindset of a physician, must be affordable. And it was really a shock to talk to a patient and have them explain to me, well, actually the reason they weren't taking their insulin was that they couldn't afford it because it was more than $100 a vial. And so then instantly I found myself thinking, well, if it's more than $100 a vial, that might be a newer insulin, a more expensive insulin. We need to switch you to the older generic form, but there was none. And digging deeper with a colleague in the Department of Medicine, we realized, we talked around to other internists, and very few people recognized that there was no generic insulin. But if you look back, what happens is the first insulin patents taken out in the 20s, as they expire by the 1940s, there's a new generation of insulins that take their place. Now, these newer insulins are better, right? They're longer acting, they're slower, they actually have a more physiological action in the body, they make management easier for patients.
And they have new patents.
And they have new patents, yeah. And they deserve those new patents. They are real innovations, the product of research. But then 20 years after that, by the 1960s, you have another crop of insulins coming out just as that second generation of patents is expiring. They have lente and semi-lente forms. They're even more physiological. They have immunomodulators that these animal-based insulins cause less and cause fewer immunogenic responses in patients. And as those expire, we find ourselves in the dawn of the biotech era with the new recombinant DNA insulins. And those expire, we have the insulin analogs. And the point I want to make is not that any of these steps was simply a Me Too drug or not an innovative process, but that we as a society don't have an available metric to value that incremental innovation versus the tail end, which is to say the loss of that older form. So what we don't see developing in the insulin space is a set of competitive off-patent markets. And this is not simply a question of bioavailability, because really these problems begin in the 1940s before we even talk about something like a biotech industry taking space. It has a lot more to do with the means by which physicians and consumers switch from one market to another in a way that doesn't happen, say, with penicillin, right? So, the penicillin you take is the same penicillin, but finding animal insulins in the American market is impossible. And in fact, if you look around the world, the shift from animal to recombinant to analog happens so broadly. And what I want to leave us on with this question, there are clearly patients who benefit from these newer insulin forms, but we have no metric for understanding the cost of those patients who would benefit from having any insulin but simply cannot afford it because that cheaper insulin is not available.
So we can talk about kind of price negotiation and managing price and saying, well, the Medicare copayment should be this, insurance copayments should be capped at $250, $500, what have you. But then what this gets at is this idea that patents and kind of the intellectual property protections we have in the US also may need to be altered in some way. In fact, when I came to this job less than a year ago, I was unaware about how many different tiers of patents there are available from the FDA for different sets of drugs, and biologics get 12 years, I believe it is. And anyway, Josh, could you speak to this idea? Do we need to manage patents a little bit better?
It's also about exclusivity, not just patents themselves.
Right.
So in the FDA world, you talk about the exclusivity, which is basically functions like a patent. Other people can't rely on your data. So you basically you still have the monopoly during an exclusive period, and there are all kinds of different exclusivities that exist. One of them has to do with doing studies on for pediatric patients, as well as when they created the biosimilars program, Congress gave a certain amount of years of exclusivity to the companies, and so people are looking at that. There's no question that has a big impact on the market, and I would probably defer to one of the economists, so where they think to draw the line. Some people have proposed varying the exclusivity based on the pricing or based on the value, which is another way to do it. I want to go back to something you said, though. I think it's important to realize that nobody thinks that the pharmaceutical industry shouldn't make money.
Right.
But at the same time, it is too simplistic to say the more money they make, the more cures we get. That is not necessarily true. And in fact, one of the logics of having value-based pricing is that then companies are oriented towards creating products that have greater value, as opposed to products that they can just figure out how to charge a lot for. And so part of the logic of value-based pricing is to organize the profits in a way that create better programs for people. And then the second point of that is, when they do make their prices, they are assuming that many people won't get treated. This is not like the polio vaccine, where they made it and then said, we want everyone to get treated. It's explicit, and you can see that in the hepatitis C documents that came out in the Senate. They're setting prices for a target of revenue. And even if I just say grant the assumption that they need that target of revenue for whatever reason, although I don't necessarily agree with that, but let's just say we agree, they are assuming that the vast number of Americans with the disease will not get treated. You can see their volume estimates. So where does that leave us as a country that wants to take care of problems like hepatitis C, or we have public health issues and we want to see the health of Americans improve and reduce our risk? So you can take the concept that companies should make money and still say we need to use some pretty extraordinary authorities to make sure that people can have access to medicines. I don't think those things are incompatible. And in the case of hepatitis C, the National Academy of Medicine just put out a very bold recommendation, which I'm in the heat of the moment in Washington, I don't think people covered enough. They said that the government should license a hepatitis C medicine and make it available separate from basically the normal commercial marketing, in order to take care of neglected market segments, which really is like the vast majority of people with hepatitis C in jails, on Medicaid, and elsewhere. And the government should just figure out a way to do an auction for a patent or a competition, buy one basically, and take care of people. And I think that those kinds of things are not averse to the idea that the pharmaceutical industry should make money, because they're still making money. These are for patients they never expected to treat in the first place.
If that recommendation were followed, who would take action? What agency would be in charge?
The HHS is the direct recommendation from the National Academy of Medicine, that they would figure out a way to basically license a hepatitis C drug.
So, just to make it in very simple terms, price times quantity, right now they're assuming, say, 20% of the people are going to get the drug at a price. If you cut the price by, make it 80%, 20% of the current price, but get 5 times more people to get the drug, you essentially get the same dollar volume to the drug company, but essentially you get 5 times more people covered. And so that's essentially what we're trying to figure out, is how do you get that? So the drug company still gets the same revenue, but we dramatically increase the price. Dramatically increase the volume.
So stepping off that, I think the idea of allowing the government to kind of negotiate terms like that and to step in and do this. You've had some interesting ideas about how to bring more drugs onto the market as well, Jerry, as far as manufacturing and getting more drugs in the market from a generic standpoint. Can you talk a little bit about that?
Well, so we definitely want to bring more, and that's really what I talked about a little bit earlier, to making sure that there is not a way to keep everybody who wants to manufacture a drug have an ability to do it. So that's what Martin Shkreli and others have done. They've created these limited distribution networks to keep people from being able to manufacture the drug, which makes it very difficult. The other part of it, and so I've already talked about that, the other part of the issue that we ought to recognize is there's been a lot of mergers in the generic pharmaceutical space, and the way generic pricing works is the more competitors, the lower the price. So the question is, how do you keep a lot of generic competitors in the market? And with these recent mergers in the generic space, we're concerned that there are not as many competitors as there used to be, and we need to essentially have the FTC and other places take a very close look at that issue.
Okay. And then jumping back to branded drugs, Josh, you caught me on the patents earlier with exclusivity. I appreciate that because exclusivity periods are something of a conversation right now in DC with the orphan drugs being a 7-year exclusivity period. There are different exclusivity periods. Should those be reconsidered right now as far as brand name drugs go? Should we think about how long we give market protection to different drugs and what the value of those are to those drugs?
I think you've got better people to ask on this panel for that question than me. I think it is a tool that policymakers have.
Yeah, and it's kind of a blunt edge tool, right?
Right. It's interesting. I mean, I was most involved in the pediatric issue. And so there's 6 months of exclusivity that companies can get if they do a pediatric trial. If that exclusivity is worth $1 billion in exchange for a $50 million study, does that make sense? You know, and so I think, you know, paring that back or making it a little bit more proportionate to the size of the study would seem to be a reasonable policy move that could balance, still create plenty of incentive, but maybe not just like, you know, a very disproportionate incentive in some cases. I think those are the kinds of questions that should be asked as part of this discussion, but I will defer to others.
I will look over here.
So I think it's for us, it's a balance between access to these drugs and the development of new drugs. So what we're concerned about when the price is so high is very limited access to these drugs. We still want to maintain the incentives for innovation, but you know, you're making a trade-off between people benefiting today and people benefiting tomorrow. And what we're seeing with these fairly long market exclusivity periods is a lot of people not benefiting today, when the pricing algorithms and all that mean that only 15 or 20% of the people are assumed to be able to afford the drug. That, for us, is a serious problem.
Go ahead.
I was just going to say, I think it's also reflected in, for instance, the Franken bill, where you see that not should we just maybe reconsider the length of exclusivity, but also that there's a lot of abuse of the system going on right now, and that there are some potentially sort of, even before trying to rethink about what the best sort of trade-off, as Daria is saying, between innovation and access is in defining exclusivity periods. There are first probably ways that we can stop some abuses that are going on right now, for instance, with the Orphan Drug Act and pay for delay and evergreening and sort of these ways that companies are right now taking advantage of some of the regulations to extend their exclusivity periods in ways that might not be appropriate.
Right. So Senator Grassley Hatch and Cotton out of Arkansas had asked the GAO to do an investigation into orphan drugs, and they are following that up. They confirmed this month that they are looking at that and whether the exclusivity periods are warranted. I think one of the surprising things as a reporter when we were looking at this is drugs like the generic colchicine became a patented drug under the Orphan Drug Act, and it had been around for decades to treat gout, and then
Millennia.
Millennia. Romans, I think, used it, right?
Jason of Colchis, right? The Argonaut, right?
Yeah. That's right. So
that
then
was an ancient Greek medicine.
A company comes in and does makes it an orphan drug. What was it for? Mediterranean fever or something? Anyway, it was for a tropical disease, and they got the orphan drug for that. And then, of course, the price went up, and you couldn't get it elsewhere on the market. Another orphan drug, and I don't think it was based on the number of people, because to be an orphan drug, you have to have 200,000 or fewer treatments of patients in the U.S., but Suboxone also qualified as an orphan drug when it was approved, and I think that was because the company didn't believe they could make enough money to have a profit off that drug, and Suboxone, as you probably realize, is an antidote to opioid addiction. So it's an incredibly popular drug these days, certainly not an orphan drug. Of course, its exclusivity period has expired, but it's just interesting to watch, to go through the list of drugs, and I think those are the kind of abuses that people are concerned about, is this idea of, well, what's the appropriate, and it goes back to that question, what is the appropriate incentive for companies? Because we're in a capitalistic market, we certainly, we're set up to provide incentives for companies to create drugs. We're largely, it's the pharmaceutical companies who bring new drugs to market. So we don't want to kind of hinder that relationship, but at the same time, what are the appropriate incentives for that relationship? Caleb, do you have anything to add to that conversation about?
Well, I mean, I think the ODA, or Orphan Drug Act, has been a victim of its own success. And, you have household names like Crestor or Vioxx or Humira, and nearly half of products that were approved in 2015 were approved with Orphan Drug Act. status. So, this wouldn't be the first time that a piece of legislation needed some reworking after it had been around for a few years. So I think it's, I'm pleased that people are looking at it and that it's on the table in terms of revisiting whether whether it's properly structured so as to achieve its intended goals. Companies have flocked to get ODA status. There are incredible tax incentives and 7 additional years of exclusivity. And for a blockbuster product, that's maybe $7 billion extra dollars in the bank. So I think the reasons that these products are achieving blockbuster status is through a combination of changes in indications, obtaining new indications, new FDA-approved indications for a product that may have been initially approved for a disease that has fewer than 200,000 people. Widespread off-label use as well is common for some of these, where the manufacturer may not get additional FDA indications approved by the FDA, but may nevertheless successfully see sales of the product for off-label indications. So I think it will be revisited, and I think there are a number of important challenges for policymakers that do so. So one is how can the incentives best be changed so as to better accomplish its intended goals is the bottom line. Are there ways to structure incentives so that, for example, manufacturers are incented based on the volume of sales that they achieve for the orphan condition rather than overall sales? Or some have proposed, for example, that manufacturers pay back in some form money after a certain volume of sales is achieved, say that after $1 billion in sales is achieved. So I think that there are a number of different proposals to try to tweak the ODA. And I think the vexing thing here, what one should anticipate, is that any effort to do so will be met with concerns that people with orphan diseases will suffer, and that ultimately, as revenue goes down for pharmaceutical firms, the innovation will suffer. So, I don't know that we've tackled that head on here, although some of us have made some comments to address that. But that is another sort of ace up the sleeve of any argument to try to constrain cost in whatever way, is that invariably, this is going to hurt innovation. And I think that we're likely to see debates around this issue of sort of what's the proper balance of rewarding companies on the one hand, yet maintaining affordable products on the other, similarly as we do in other settings when it comes to the Orphan Drug Act.
Right.
Since we're researchers, we're also trying to just look at the trajectories that are going on. So we're looking at all the recent orphan drugs that have come on the market and trying to figure out how many different orphan statuses did they have, and then did they start as an orphan drug and go to a broader drug, or did they start as a broader drug and then do orphan status? How often does which one of those occur, so we can get some basic knowledge about the orphan drug trajectories that are ongoing.
Right. Gleevec, for example, is a cancer drug, very common cancer drug. It has 9 orphan designations, or indications for it. It's an interesting process. Orphans get designated, then they go through the clinical trials, and then once they have marketing approval, they still have their orphan status, and then they get the 7 years exclusivity. And I think that the same questions could be asked about the other exclusivity periods too, although I haven't looked at those as closely as a reporter. But surely the questions about whether 7 years exclusivity period for the orphan drugs could be applied to whether 12-year exclusivity period or 5-year or whatever. There's different exclusivity periods for different drugs, which I don't think a lot of consumers realize, that there are these market protections for these drugs.
Yeah, I think the best way to go about it is empirically. You can see what it's been worth, how it's been used, and then putting on the table reasonable changes that are really based on the facts would be a good way to go. That's how I would think around pediatrics you could do it, or the Orphan Drug Act.
Well, I asked the FDA, my colleague Sydney Hopkins and I asked, can you tell us how many patients have been treated with orphan drugs? And they don't track that. They don't track the number of patients treated with the orphan drugs.
Well, so it raises an interesting question. So here's a question for you as a reporter. Mm-hmm. Who's responsible for prescription drug prices in the federal government?
Nobody.
Nobody is, right? I mean,
Right.
so the FDA doesn't track that. Well, I mean, but why would they track it, right? I mean, what's the they're not administering the exclusivity. That's part of the law. I mean, they just make the designation. You know, the big picture is not the responsibility of anybody in the federal government.
Right.
And that is, so you have this weird situation where you have such an incredibly interesting and important public concern, something that is having the different effects that we've all been talking about on our insurance rates, on health, on public health, and yet nobody really, there's not one area where it's all being coordinated and people aren't, or even coordinated, looking at it. I mean, the federal government generally doesn't look at it. And you've seen parts of the federal government kind of step up a little bit more to this issue, but it really hasn't been invested with the authority to really look and really be strategic. And if that were to happen, I think there would be more opportunities for progress.
What you have to take a look at is how many different purchasers of pharmaceuticals are there in the federal government. So you have the VA, the DOD, the Bureau of Prisons, Medicare, Medicaid, all these different federal agencies, all using very different formulas, very different approaches to purchase drugs. Whereas you look in almost every other country, there is one general purchaser for the UK or for France or whatever. You know, the United States has a very strange system broadly, but it also has a very strange system just within the federal government to do something like purchase drugs. And, you know, so one of the things we're taking a look at is whether or not the formularies across the different public programs are all that different, or are they effectively the same formularies? And we're just trying to see it. And then, you know, how is that related to the prices that the different parts of the government are paying? Because there seems to be, according to CBO and other places, fairly significant differences between what the VA pays and what Medicare pays for an identical drug.
I think we may be running out of time, but I do want to kind of follow up on what Josh was just saying and what you're saying, Jerry, and this idea of looking at the different purchasing and the different ways we pay. The states have been stepping up to kind of evaluate and lots of different proposals across the states on how to look at drug transparency and drug pricing. Maryland is actually making some headway on this, and I believe some of you have worked, have testified in the Maryland legislature. So Maryland has two different proposals, one on price transparency and one on controlling prices, right? Can one of you talk about, Jeremy, are you the best person to talk about this?
Sure, well,
It's something that should be on our radar screen. The reason I mention it is because it's really very interesting, and I think lots of people are probably watching it.
Yeah, I mean, it's quite important and it's very timely. There are two bills in front of the Maryland Assembly right now, one concerning transparency, the other concerning price gouging. And the latter bill, the price gouging bill, is being discussed today in the Senate Finance Committee. The House version already passed.
Yeah.
And what this measure would do would be to give the Maryland State Attorney General the ability to prosecute egregious price gouging under unconscionability law. So for off-patent drugs in non-competitive markets,
Yeah.
generics in non-competitive markets, so only if there are 3 or fewer manufacturers, and only if there has been an egregious price increase. And
So it kind of dips its toes in the water of price controls.
it is a beginning, but it would be an effective, it's quite fascinating because one of the statements that Martin Shkreli kept on making in front of Congress and other audiences, that he raised these prices because he could, and there was nothing anyone could do to stop him.
Right.
And so there still has yet to be an action taken that would stop a future Martin Shkreli, and this would be really the first.
Okay, well, let me open that up to questions. I think this feels like a good time to open it up to questions. So does anybody have any questions for our panelists? Obviously, it's a wide-ranging expertise that they have, so name it and they can probably answer it.
Sure. Hi, Joyce Frieden from MedPage Today. I want to ask Dr. Anderson, can you elaborate more when you talk about how the price of a new drug isn't necessarily related to the R&D costs? Like, how does that work? Are they spreading their R&D costs across various drugs?
So it depends on whether or not you're a Pfizer or a very large company, and then you would in fact spread your costs over a number of products and try to make most of your money out of, generally about 2 out of 10 products make a significant amount of money in a company like Pfizer, and 8 break even, don't do too well, etc. So you're trying to make your money on generally about 2 out of every 10 products on those things. But when you're going to price, you're pricing it on what is the substitute drug going to cost right now or something else. You're not typically pricing it on the basis of how much did you put in R&D into that particular drug. So that it's a disconnect between the amount that you put into a drug for that drug and essentially the price of the drug.
Bernard Munoz over at Faster Cures has actually done an analysis of companies and how much they're spending for R&D. So I don't know if you guys have done an analysis like that.
We have done
but
the same thing.
Okay, so you can find those ideas of who's doing best at not spending as much money on R&D and still bringing drugs to market, right?
Right. So we looked at 3 of the major drug manufacturers and found that they all spent about exactly the same to actually develop the drug. It's about $1.4 billion over the past 15 years. And all 3 of them was almost with the penny is how much they spent to develop new drugs. Now, you also have to include the cost of capital, which is why the $2.6 billion is so high. A lot of that cost is the cost of capital, because you start the process, you have to invest a little, and then the drug doesn't come available for 5, 10, 15 years later, but you've invested all that upfront cost of capital. And when Tufts does it, they assume the cost of capital is 11.5%. And I wish I could get 11.5% on my investments, but that's what they assume that they can get on their investment. So we have taken a lower number of the cost of capital than they have, because you can borrow, as a big company at 2 or 3%. So it would mean a significantly lower number. But it was just surprising to us that these 3 big drug companies cost exactly the same amount of money to develop a drug.
Yeah, you would think some of them have brought more drugs to market. So.
Some of them have, but then they have invested a little bit more, and so it's basically $1.4 billion.
Any other questions in the back here?
Oh,
If you could grab a microphone.
No, she's got one.
Oh, okay, right here. Sorry, we've got to do the mics, so we'll get.
okay. Kat Lucero with the Hill Extra. Tom Price last week said at the panel that he and the White House is working on a strategy to lower drug prices. What could that be, and what's the possibility?
Yeah.
Well, what could be that strategy? What could be in that package of a deal that would aim to do that?
Right. President Trump has said he wants to negotiate drug prices for Medicare, but there are a lot of other options out there that he could choose from. So what are you guys hearing?
I don't know that we have an answer for you on that one. That's something that we're not privy in terms of those conversations. If you look at where the expenditures are growing, it's in 2 big areas. One is the specialty drugs, which are coming onto the market, are very expensive, where in the case of Medicare, you can't negotiate prices. And so that's one of the areas that I would take a look at. The other area that I would take a look at are generic drugs that do not have any competition, the Martin Shkreli kinds of areas, and trying to get those. So, he hasn't asked me, but if he were to ask me, those are the 2 places that I would say where the potential for savings are.
Anybody else?
I would just say I think presidential leadership on this could be quite important. I think when the president sends out a tweet about drug pricing, the entire pharmaceutical industry shivers. So I think that whether they're serious, we'll see when we see proposals. Are they the kind of proposals we've been talking about that could have a big difference, or are they just sort of around the edges? I would also say that I think in covering this, it's really important to put it in the context of some of the proposals on coverage, because it is very, very difficult to imagine progress on drug prices while 24 million people lose health insurance. And I think those things are at odds. They're not 2 completely separable conversations, because coverage is what allows people to be able to afford to get medicines. And so without coverage, many people can't pay the prices, and so that creates more pressure for higher prices.
Yeah.
But
Access.
Even
is
if
the
people
word.
do have essentially coverage, like in the Medicare program, if a drug costs $100,000 the Medicare beneficiary has to go through all the stuff to get to the catastrophic amount and then has to pay 5% of the cost. So the Medicare beneficiary for a drug that costs $100,000 can get an out-of-pocket bill of $10,000, $12,000. That's not affordable to somebody who's on Social Security. So even having coverage doesn't mean that you have access to many of these drugs.
It does
And I
seem,
think it's easy for us to underestimate how small an amount of money can make the difference between a patient deciding to take their medicine or not. And there are very well done scientific studies showing that even $1 or $2 increase in copayments for a Medicaid population can lead to important declines in rates of use of medicines for chronic conditions. So, even 5 or 10 years ago, predating all of the recent interest in drug pricing, even then we were living in a setting where 20 to 30% of individuals, Americans, reported that they skipped or stretched medicines within the past year due to costs. So one can only imagine the magnitude of cost burden as it's grown over time, and in particular with these, the specialty products they account for a very small amount of drug use, but a very large amount of spending. And so there's a slice of the population that's really hit hard by these bills of, $5,000 or $10,000 a month. But there are millions of Americans that are just shelling out, $75 here, $50 there, and are deciding not to take their medicines as a result.
Right, so it's really that the proposals on health insurance are very relevant for two reasons. If the whole purpose of trying to lower drug prices is for people to be able to afford their medicines, then taking 24 million people off of health insurance is a massive step in the wrong direction. And second of all, there's pressure for increased prices because fewer people can afford the prices now.
let's jump back here, I think. You have the mic, you have the power.
Forward when you're done.
My name is Michelle Forsley, and I work in international health development around the world. And I manage these kinds of problems in lots of other countries. So I'm very familiar with the research that has been done over the cost of health care, how to pay for health care, how do countries buy drugs. All of that kind of information is what I work with all the time. And I find myself, having just gone into Medicare, saying to myself, there must be something that we can do about the United States. Now, what is that? So my question to all of you is, what are the subjects or the disciplines or the areas of inquiry that we have not looked at in terms of this problem? One comes to mind, for example, in that I don't understand why Medicare isn't subject to the federal procurement requirements. That instead of negotiating, so to speak, why aren't they issuing international public procurements to buy drugs or to set prices under framework contracts, for example? Why aren't we using the UN Convention Against Corruption to look at some of the questions we are facing? Why isn't the federal government, for example, HHS, responsible to protect the health of the public? I thought it was. Why isn't it? And for that matter, therefore, US FDA is responsible to protect the health of the public. So what are we missing out here in our looking at this problem? When you were talking earlier about that the US FDA doesn't look at pricing, but it looks at shortages, why isn't it looking at how prices are done around the world? We do studies, for example, through USAID on the prices of drugs in lots of other countries, and you can look at international price indicators that MSH puts out, for example. Those are relevant to the United States population, and where we have such a substantial price differential on a particular drug, whether it's a branded drug or a generic drug or for an orphan illness or whatever it's for, why aren't we asking the question that when that drug is so out of price in relation to the affordability of people, whether they have insurance or not, put that question aside for the moment, why isn't that a call to action for FDA to step in and use some of the mechanisms available to it to bring that product into the market? And the other issue is looking at the question of importation. What does it mean to import a drug? When we import active pharmaceutical ingredients, when we import lots of drugs because they're manufactured all over the world, what are we saying we're not doing when we say we can't import drugs? What
Well,
are we
let's-
saying?
Let's kind of go back to the price question first. We know that Medicare is not allowed to negotiate prices, right? We also know that the FDA does not consider prices when approving a drug. So, so why don't we think about prices in the U.S.?
I think the issue has to do with the question I asked you: who's responsible for drug prices?
Right, 'cause
the
nobody-
FDA sees its primary responsibility is the safety and efficacy of products on the market. And they do get involved in different market dynamics, particularly shortages. And I think what we propose is that they do get involved in a type of shortage, which is a shortage of generic drugs caused by egregious behavior on pricing. But that is really a small part of the overall pricing challenge. And it's not going to be FDA that is going to be setting prices. If there were, or
Right.
doing any of these other policies, there's the FTC, there's CMS, there are many other parts of the government. They need to be coordinated, and there needs to be a strategy. And there are tools the federal government has. I think just because there are a lot of people who think about drugs at the FDA, it's wrong to think it's the FDA's job to do all of those things. On the other hand, it's got to be someone's job. And really figuring that out. I mean, I have been involved in running large organizations. If you care about something, you put someone in charge of it. You figure out what your strategy is, and the federal government has yet to do that on drug pricing.
Yeah, do we care enough now? Are we going to see some movement on putting somebody in charge of drug prices?
So, I mean, again, as Jerry suggested before, I can't answer that question not knowing what's in people's heads right now. But I wanted to
If only
add
we
that,
did.
that this is not an act of omission, right? Historically, we have built a healthcare system specifically so that price cannot be part of these negotiations. It was part of how Part D was built, right? It was part of how comparative effectiveness research was built when funding the United States. That we construct the system collectively, legislatively, so that price cannot be talked about. And the point I want to make beyond that domestic arena is also internationally. If you look at a term like essential drug, which often gets brought into questions like this. The Essential Drug Policy Program was developed by the World Health Organization in the 1970s, right, to define these typically older medicines of priority need in public health. And initially was left open as a question. These are of priority need in public health anywhere in the world. But in negotiations with the United States and the World Health Organization, is explicitly formulated that essential drug policy only applied to the developing world. So there's a question of how an insulator could be built between the kinds of practices you're talking about that USAID would have been involved in trying to get cheap old drugs to elsewhere, and ways in which those policies might reflect back onto problems of generic drug availability in the United States. So that insulator was actively built, not accidental.
It's an
If
interesting
you
international
wanted to
perspective.
know how much at the DOD it cost to build a B-1 bomber, you could find out. If you wanted to know how much they paid for a particular drug, you can't.
We'll go to that question.
Is this on? Yeah. Hi, my name is Sally Greenberg. I'm director of the National Consumers League. It's great discussion. One of the things that comes up over and over again when we go on the Hill or talk to FDA folks about drug pricing, and even industry folks, they'll say, well, the fact is the United States subsidizes the rest of the world because drugs are so much more expensive here than they are anywhere else, and the rest of the world benefits from that, but we apparently can afford to and do pay for these very high costs of drugs. And so my question to this panel is, do you think that's true? Is the return on investment for us and the rest of the world, is it a good return on investment? Are we incentivizing the development of very badly needed drugs for Americans and for the rest of the world's population? And what effect does that have on our healthcare system?
Yes, not as well as we could, and it's much more expensive. Those are my three answers to that.
I feel like we've reached a tipping point, though. I hear the same thing a lot, that we're subsidizing the rest of the world and that it's because we can't afford it. I feel like when I hear somebody somebody on the Hill say, I've reached a tipping point with this drug price, I feel like that's kind of an overall thing. Like Americans have reached their max. Like Congress is realizing that Americans have reached their max. We can't, when people cannot afford their drugs on a consistent basis, even with insurance, even with Medicare, I don't know, I feel like we've reached a tipping point. And let me just kind of ask you guys, is it time?
I mean, I think just one thing to say about this is that it sort of gets back to this question of value. And are we going to have a conversation about how we want to value these drugs. We have a system, as Jeremy is saying, that has avoided that on purpose for a long time, and it's made a lot of these conversations very difficult. And so I think that's something that we're going to need to think about. Right now, we have a system that basically rewards both developers and providers pretty similarly for drugs that have really huge incremental benefit, of which I think we have a lot of those drugs that are developed in this country and that serve the rest of the world as well. But we also reward, not that differently in a lot of cases, drugs that have a very small incremental benefit. And that's inefficient for consumers and taxpayers, and also not helpful in terms of sending a signal to developers about where to invest and where we want to place our value and spend our money.
And we're seeing that conversation really come to a head with cancer drugs, it seems. That cancer drugs themselves, when you see them providing incremental benefits with side effects that are very bad sometimes, and the prices are still very high. We're seeing that in the media, a lot of stories about that right now.
So I don't think the incentives are exactly right. You've got to change the incentives. And I think if the drug prices are such in the United States that only 15 or 20% of the people that have something like hepatitis C are able to get it, there will be a backlash that, everybody in the UK gets the drug and only 20% of Americans get the drug. That's just not fair.
And I would add in as well that part of the problem we have in this kind of a conversation is that we're so relentlessly focused on innovation when we talk about pharmaceuticals in the United States. Now, as several of us have talked about today, there's a balance of innovation and access, and it gets shaped by different forms of regulation, different moments. The Orphan Drug Act, we talked about the Hatch-Waxman Act in '84, which helped the balance between the brand name and the generic drug industry. And yet, if we look at where we are right now with December Congress successfully passing a 21st Century Cures Act, but not being able to take action in ensuring that Americans have access to 20th century cures, we have a form of drug pricing that is so skewed towards innovation that we have a hard time really talking meaningfully about access right now. And I think that may be the tipping point that Sarah is referring to. How do we restore some sense of confidence and access to the innovation that we support with the American drug system?
We passed the 21st Century Cures Act, but not being able to take action to ensure people have 20th century cures. I think that's a great note to end on. If we don't have one more question, do we have one more? Okay, two more? Can we fit two more in?
We have to wrap it up very quickly.
Okay.
Why don't we do both questions back to back?
Okay,
Is that okay?
so this is
Yeah.
the first one.
Thanks. I want to come back to the value-based pricing that Jerry had started talking about, and it's been a big issue in terms of value-based pricing, not for drugs, but for a lot of things, and how that relates to the ACA and the future of that, because fundamentally the ACA reshaped the business model for insurance in this country to take it from avoiding risks to managing risks. And managing risks is all about trying to get the greatest value for what you're spending. If changes to what we have now as current law, which I'll call the ACA, moves the insurance companies back towards a system where their business model is avoiding risk rather than managing it, does that undermine the movement or the incentive to do any value-based pricing, value-based contracting, or am I missing something?
Next question.
Next question.
Hi, my name is Sarah Kasawa, and I work on the Senate Aging Committee. Dr. Alexander, you mentioned coupons, rebates. Everybody loves coupons, right? But we know that they can be misused. Is there low-hanging fruit in that area?
Yeah, I had some questions prepared about that, actually. We just ran out of time.
Yeah, well, maybe I can take that one very quickly, and then others
back
can address the first one. So I think the coupons for, well, first of all, discounts, and there are many other forms of patient assistance programs and the like that actually are more common if you look at a proportion of all pharmacy transactions than coupons per se. But where these, I think, particularly disrupt or distort the market is for multi-source products. So for branded versions of products that are available as both a branded and a generic version, where these are used essentially to offset or wipe out or obviate the amount that the patient would be paying. So the patient isn't exposed to any copayment or a reduced copayment. And essentially these undercut the ability of pharmacy benefits manufacturers and insurers to use any economic incentives to try to steer patients towards a better buy, a more value, more bang for the buck. So I think that's the lowest hanging fruit. I think there are more complicated questions about the role of coupons in other settings. But I will point out that Medicare and Medicaid forbid coupons, and for good reason. And so it's interesting, and I guess I put the question back to you and all of you, why is it that Medicare and Medicaid don't allow coupons, and yet they're so prevalent in the commercial market?
And I'll also just add to that there's, even though consumers are protected from those copays at the point of buying a prescription, the insurers are still paying the higher price. So eventually it's also possible and even likely that as the insurer cost rises, those costs will be passed along in the form of higher premiums. So it's not necessarily that the consumers are wholly insulated either.
And it encourages the consumers to seek the higher price drugs, thus encouraging the higher prices and the drop down to the premiums.
Exactly.
But then the first question, and forgive me.
So essentially it's about value-based. So what I would argue is that in a large extent, pharmaceuticals have been left out of most of the value-based discussions. They haven't been part of it. And so, the question is, if we move forward with more value-based purchasing, how do we get the pharmaceutical industry part of that? Pardon? That was my question, but go ahead. Sorry, what was
ACA insurers taking risk or
Versus
managing risk or avoiding risk.
Right.
If it slips back, what happens here? Right? Is that and so I think there are a lot of reasons to hope it doesn't slip back. And this is one of them. The approach of paying for value generally in healthcare is extremely important for patients and for costs overall. If it does slip back, that is going to create a challenge on the issues that we're talking about, as well as many other challenges along the way. And I think it's one of the things that's kind of in the balance with some of the discussions on the Hill right now.
Right, I think we are out of time with this room.
Well, let me first of all thank the National Press Club. Let me thank you, Sarah Jane, so much. Everybody, I would also like to thank the Laura and John Arnold Foundation for supporting a lot of the work we do at the School of Public Health on drug pricing.
They also support my work over at Kaiser Family Foundation, Kaiser Health News. So
great, and thanks to all of you for attending.
thank you.